Hi, I'm Caitlin Carter. I am making this video for the prenatal complications required skill module for Clinic 3050. This is talking specifically about prenatal bleeding and hypertensive disorders. So with prenatal bleeding, I feel like it's most important to ask all the right questions to figure out kind of where the bleeding is coming from. Hopefully we know the client a little bit, but oftentimes we won't. If a client is, maybe she's come in for a prenatal visit, maybe she consulted and wants to come in. A lot of those early miscarriages, which can be one of the reasons for prenatal bleeding, are going to be in those early weeks in the first trimester, typically. Obviously, there's other reasons as well. But so I'm asking questions like, have you had intercourse recently? How much blood is there? What color is it? How long has this been going on for? Just kind of all of those old cart questions. Just really getting kind of the full clinical picture of what's going on. Hopefully, a lot of times we will have had that initial set of labs, so we know if we will have already done labs. Are there STIs involved? Are there any vaginal infections? We would have done a urine culture, all of that type of stuff. One of the other things that I would be asking about is pain. Just asking questions specifically targeting, like, is this an ectopic pregnancy? Like, yes, you had a positive pregnancy test, but where is the pregnancy located? Something else to consider is, like, how big their uterus is, depending on whether or not we've done any hormone testing. Is there a possibility of a hydatiform mole? Have they had any abnormal cervical stuff in the past that might indicate a reason for bleeding? And abuse. Trauma is also something that can cause vaginal bleeding. Drugs as well, substance abuse. So I'm going to be going through and asking those types of questions, and based on those questions, we can kind of figure out, like, what's going on here. I'm going to be considering the gestational age, and, is the simple implantation? Is it postcoital? Are we looking at a subchorionic hemorrhage? Like, do we need to, one of the first things that I may indicate if it sounded like we needed to is to have her going for an ultrasound. Like, let's just see what's going on. If she's a little bit further along and we can listen for fetal heart tones, come into the office and let's listen and try to kind of pinpoint more of what's going on. Something else that we could consider is, again, depending on how far along she is, the serial HCG testings that are 2 or 3 days apart, to see, like, are we still trying to get into a pregnancy, kind of what's going on there. I would want to run a CBC as well. Depending on how far along the client is, we should also know her blood type and RH status. If she is bleeding, if she is miscarrying, is this an indication to give RhoGAM? Obviously, all of that is going to come into consideration as well. Let's see. If it's in the second or third trimesters, we could do an NST in the office. My preceptor has the equipment for that, so we just can offer that in the office, just to check baby out and see how things are going. If those initial screens have been done, oh my gosh, there's just so many possibilities. We had a client come in just this morning that had brown spotting. She's 30 weeks, 29 weeks, something like that. And it was kind of a lot of brown spotting. Came in and talked through all of those details. We ultimately decided to just do a BVV swab culture that, see what's going on. Is there an overgrowth of bacteria there? Does she have Gardnerella? Something like that. Basically, we're going to run some tests and do an ultrasound, make sure the pregnancy is viable. If it's early on, we can make progesterone recommendations. Yeah, I mean, we can offer a sterile speculum exam. I feel like I'm not totally sure exactly where to go with this because there's a million reasons for prenatal bleeding, and all of the answers as to what you're going to do with those things are going to be very different. But basically, we want to make sure the client is not bleeding like to the point of hemorrhage, and also keeping in mind that a first trimester hemorrhage is going to look a lot different than a third trimester hemorrhage. Something else that we could be considering is, has she had an ultrasound? Do we know where the placenta is? Like, are we looking at a partial previa, an abruptio placenta? Could something like that be causing the bleeding as well? I forgot about that. And how we're going to treat it is going to be very dependent on what the cause is. It may be as simple as some spotting after intercourse and nothing to worry about, all the way up to, needing much further more care, just depending on what it is. So I think I will stop rambling and yeah, I think that's good. I'm going to make another video for hypertension because this one's getting really long. Thank you.